And welcome to this RCPCH and BPSU series webinar on Catch Us Before We Fall, Transitional Care for Young Adults with ADHD. Today's webinar will be presented by three speakers who will introduce themselves shortly. The webinar presentation will last for approximately 30 minutes, following which we'll have a Q&A session. For those of you that are new to webinars, if you would like to submit a question to the speakers for today, you can do it at any time during the presentation or during the Q&A session. To do so, there's a questions tab, which is on your GoToWebinar software on your screen. And please type in your questions clearly, and we'll take those at the end of the presentation. We'll also be recording the webinar today, so if your colleagues have not been able to join us today, the recording will be available in approximately a week's time. And those of you that are joining us today, you'll also receive a copy of the recording link when it's available within about a week's time. So without further ado, I'll now hand over to the speakers to start the presentation.
Good afternoon. Thank you very much for your interest in the Catch Us study, which three of us will talk you through, and then we're very keen to hear any questions you have. So my name's Tamsin Ford, and I was the PI on the study. Now we thought, as an academic, it's a really good place to start is the definition of transition. Children grow up, and if they have a long-term health problem, they will need to move from a child-centered set of services to an adult set of services. This is something that pediatrics, I think, has had longer to work around, but we are talking here more than just the administrative transfer of case notes and where you go to see your doctor. And so, bearing in mind our findings as you go forward, we are basing the term transition on the definition on your screen. So something that is purposeful, planned, and addresses not only the medical needs of the young person, but their psychosocial, educational, or vocational needs as well as they transition. Now, I first got interested in this when working on the TRACK study led by Swaran Singh. As I said before, pediatrics, I think, has worked more intensively around children with long-term conditions like epilepsy and diabetes, and actually has a better conceptualization than mental health services, which are increasingly becoming focused around episodes of care, which doesn't quite fit with a long-term condition. So Swaran led the TRACK study, which explored transition from child to adult services for any mental health condition. And it won't surprise anybody that we found very few young people had an optimal transition, but it seemed that young people with neurodevelopmental problems were served particularly badly. And that fitted very much with my clinical practice. It's a huge concern for parents and young people with ADHD. And so we formulated the Catch Us study to study children in ADHD in more detail, because there weren't sufficient numbers in the TRACK study to really unpick what was going on for them. So we thought it might be useful to share with you the experience of having ADHD as an adult. So we have a video of one of our patient and public involvement helpers with this study, who's going to tell you about his experience.
When I first got ADHD and I looked up on forums about medication and what it means and what you should take and what it actually does for you, there's a bunch of people saying, I don't need medication anymore, I've come off it, and it's not good for you and it's not healthy, and it's something you use as a pick-me-up like caffeine to get you over those bumps and hurdles in life. People stop taking it when they come out of school and when they're in slightly less pressured environments. But for me, when I've taken it, it's actually been like when my brother went to the opticians and he realized he needed glasses. He got those glasses, it improved it for him, and he didn't think he was weak for needing glasses. As soon as I got my medication and I stopped trying to use it for a little bit, it was like being underwater. Everything was slowed down, I was less able to focus, and I was only doing it because people told me that there was stigma attached to it, when actually it was incredibly helpful for me. Taking the medication, if it works for you, and just continuing to get support for ADHD is really, really helpful.
So I think please listen to the rest of this presentation, bearing in mind that Scandinavian registry data suggests that carrying on with medication for ADHD into adulthood is associated with lower rates of depression, lower rates of unemployment, lower rates of suicidal behaviour, and lower rates of accidents, convictions, and involvement in violent assaults. So there are some very important health, social, and occupational reasons for treating adult ADHD. There is some guidance for us that should be informing what we do from NICE for those people in the UK. There is guidance both on transition in general, which stresses that it's the responsibility of both child and adult services, which I think is really important to emphasise, but also that transition should involve young people and their families. It should be developmentally appropriate and focused around their needs, and there should be planning early with support before, during, and after. I'm sure any clinicians watching this would not disagree with any of that. Then in terms of ADHD, Trust should be providing training for both child and adult practitioners. Young people should be having regular contact. Medication should be available if required, and it stresses shared protocols with GPs, with the need to reassess young people and to transfer information between the two services. Well, on that background, those guidance came out whilst we were collecting data for the Catchers study, which asked 3 questions. Firstly, how many young people need ongoing support for their ADHD once they're too old for children's services? It may seem ridiculous, but we really didn't have good data on this. How can you commission and plan services if you don't know how many people you should be serving? So we attempted to address that using surveillance methodology, which I'll tell you about in a minute. We then asked how many and which areas do have services for young adults with ADHD and what do they offer? And that was addressed using a mapping study. And then we had a large, important qualitative study which described the experience for young people, their families and professionals working with transition. Now, there are 3 of us here today who are presenting the work of a very large group of people, a very strong team, and we just want to acknowledge our team of people behind this work. So moving to the surveillance study, some of you will be familiar with the British Paediatric Surveillance Unit, BPSU, and also the Child and Adolescent Psychiatry Surveillance Service, CAPS. You may be surprised that a study about ADHD was accepted to run because these units usually study rare conditions. Well, ADHD is not rare. In fact, it's one of the commoner reasons for children to go to child mental health services. But as the TRACK study suggested, transition at all, let alone good transition for patients with ADHD is. So the surveillance definition we used were consultants were asked to report children approaching the service age boundary, so within 6 months of being too old. If they were seen for the first time, we didn't want them to repeat them if they saw them more than once within that 6 months, who had a diagnosis of ADHD whenever that had been made, who was receiving medication and who wanted and needed to continue it. We had about 600 notifications and we got baseline questionnaires on just under 400 of those. We improved the response rate by actively chasing very hard and contacting clinicians and asking them why they hadn't sent it back, and this bumped up our response rate a little bit. Because it usually turned out when there wasn't a return that the clinician had realised that the case wasn't eligible. There were a few duplicate cases, but I don't think it'll surprise anybody that these were not children seen by both paediatrics and CAMS. They were usually somebody making a mistake and reporting the same same children twice, and actually throughout all the surveillance studies that have run on both units, we have very, very rarely, if at all, had children reported by both services. We then sent a follow-up questionnaire to the reporting clinicians 9 months after the notification, with the idea being that the young person would have had to be at least 3 months past the age boundary by that point and should have transitioned. We got a good response rate at that point, and again we're able to bump it up a bit further by checking the reasons for non-return where we could. That was often that somebody had retired or had moved on, was a locum perhaps, particularly in CAMHS, and that has implications for how we work with people long term, I think. It won't surprise anybody that the vast majority of cases were reported in England out of the four nations participating. But I think what might be surprising is how similar the patterns were between the two surveillance units. The social demographic characteristics of the cases that were reported were mostly male and mostly white British, which would predict the attendees at community paediatrics and CAMHS for ADHD. So that gives us some reassurance that our data is robust. About 2/3 of the children had more than one mental health condition, and for about 1/4 of them, it was an autism spectrum condition. So these are children with complex needs. The age boundary for both paediatrics and child mental health services was mostly centering around the age of 18, but for paediatrics there was more variation, and there were some areas where after 16 you had to be in education, for example, to access ongoing paediatric care, which is problematic because the constellation of difficulties that comprise ADHD make education very difficult. And this group, I think, are particularly likely not to carry on with education. Most were referred, about 3/4 were referred elsewhere. And again, the pattern of referrals is strikingly similar between the two units. If you look on the slide in front of you, most were referred, if they were referred to a specialist adult ADHD service. But I'd like you to note the 10% or more who were referred to primary care, which we'll pick up in detail later. So 75% were referred, almost 2/3 of those referrals were accepted, but only 1/5 attend their first appointment. So there seemed to be two big dropout points around the referral and around actually getting to that first appointment. We replicated the track findings in the optimal transition, which the far right-hand screen shows you how we defined it. It's quite a low bar, but optimal transition was actually incredibly uncommon. So the bottom line for those that commission and provide services for young adults with ADHD is you can expect somewhere between 270 and 600 youngsters to need ongoing medication per 100,000 people in your population served who are aged 17 to 19. However, you need to take that with the fact that it's necessarily an underestimate. We've had rising prescriptions of children with ADHD, so that is a snapshot now, but as those rising number of children identified with ADHD who take medication, we can expect there to be an increasing cohort of young adults who want to continue. It doesn't account for any of those who can't or don't want medication, who might want and benefit from psychosocial support, and it doesn't account for those whose ADHD is missed in childhood, and we know quite a large chunk are, so you can expect some people to present with problems for the first time in adulthood. So I'm now going to hand over to Tamsin Newlove Delgado, who's going to talk about the mapping study.
Right, good afternoon, everybody. I'm just going to summarise some of the key points from our mapping study. As with the other studies here, you can find a lot more information in our papers and our report. So why map services? Guidance recommends that people with ADHD should be treated by specialist teams who have expertise in ADHD, but we find there is often a lack of information for patients and for clinicians about existing services and what's on offer, whether that's they might be looking for a service to refer a young person to, or they might be looking for a service for themselves. And therefore, we planned our study to act as a resource for public and professionals. Our study draws on the perspectives of multiple stakeholders to map services. That means that we used online surveys and freedom of information requests to ask multiple groups, including patients, professionals, providers, and clinical commissioning groups about services that they knew of, that they provided, or that they'd had contact with. And we also included services that had been mentioned as part of the surveillance or qualitative study, so we had a really comprehensive picture. The question that we asked was, do you know or have you had contact with or do you provide any service that treats or supports people with ADHD who are aged 18 or over? And then one of the things that we did with the responses is we categorised them as to whether or not we would call them dedicated services. The term dedicated services were used to differentiate care which was being provided in maybe a generic adult mental health service from services where there was a specific team for adult ADHD. So for these specific services, the dedicated services, we confirmed provision through freedom of information requests to commissioners, and then we gathered information about exactly what was provided by that dedicated service. So that included whether they provided a specific transition service, whether they did diagnosis, treatment and consultation. Some services, for example, would only provide diagnosis, some would only provide treatment, whether they provided medication management, whether they did shared care, and whether there was any kind of psychological service on offer. So we had more than 3,000 responses altogether, and we've made this map here, which is of the dedicated NHS adult ADHD services that we had in the UK. And as you can see, service provision is very patchy. We have mapped this against population density, and whilst, as you'd expect, there are more services concentrated in areas where there are more people, there are also areas of the country, whole swathes of the country, where there appears to be no dedicated service for those young people and where they may have to travel a very long way. We've also made this into an interactive map of services, and this means that you can click on any of the services that are on our map and you can find out more about them, including the service website if there is one and what's offered. And very kindly, the UK Adult ADHD Network have now taken over the hosting of this map. So if you click on this web link, you can have a look and you can have a look at the map and see how that works. So this is a resource that we've now developed to be used by the public and by professionals. So just a brief summary of what we found with this mapping surveys. We found gaps in service provision for adults with ADHD. We found that psychological treatment was provided by only about half of dedicated ADHD services. And we found that we need to address both equitable service provision and the availability of information about these services for public and professionals. I'm now going to pass on to my colleague Astrid Janssens, who's going to talk about the qualitative study.
Thank you very much, and a warm welcome to everyone out there. A qualitative study was conducted because understanding stakeholders' views and experiences provides insight into why an intervention, in this case a transition, might fail unexpectedly or has unanticipated consequences, or why a successful transition works and how it can be optimized. We believe it to be a very important component of service evaluation and development. So for the qualitative study, we had three aims. It was to explore how different stakeholders experience transition, identify factors that influence both the quality and the experience of the process of transition from children to adult services, and identify factors or processes that underlie continuing or discontinuing medication or treatment when approaching the service age boundary. Stakeholders were young people with ADHD at different stages of transition, their parents, and clinicians both ends of the process, as well as the GP, which seemed to be the missing link and were added to the study at a later stage. As Tamsin already has mentioned, it was a huge piece of work. In total, we conducted and analyzed 144 interviews. I would like to thank again Helen and Anna, who are not here today, but who've done the bulk of the interviews. We sought a diversity of transition experiences by maximum variation purposive sampling. So we had a sampling framework set up where we tried to include different NHS regions, different ADHD service models and patient comorbidities, as well as ages and years of professional experiences when we worked with the clinicians. It's a fully integrated mixed method study design, which means that we recruited professionals through both the surveillance as well as the mapping study. So via the surveillance and the mapping study, we were able to approach clinicians who are actually working with young people with ADHD. We included 3 different groups of young people to get a longitudinal overview of what happens through the course of a transition process for young people with ADHD. And in particular, group 1 and group 3 were sampled because we know from previous work in primary care prescribing that there's a steep fall in prescribing prevalence of ADHD medication over this transition period. And actually, there's a disparity between the expected age-related decrease in symptoms and continuation of medication. Hence, we wanted to try and answer the 3rd question of our qualitative work by working with these young people before transition and those who actually had dropped out and disengaged with services, however, re-entered later on. This is an overview of our qualitative analysis. As mentioned before, there was a lot of people involved in this work, and we worked through a thematic and framework approach meticulously for each of the sampled groups, and then used the framework approach to compare and contrast themes between the different groups. Just to illustrate the 3 different young people groups, it's, I think, interesting to illustrate that we did manage to get both boys and girls included in these groups, and that those pre-transition were all indeed in education, and confirmed what we already knew from the surveillance study, that there was a high proportion of comorbidity. Group 2, I think, was the hardest group to recruit, and that might sound a bit strange, but it meant that young people had to have transitioned into adult services and have had their first appointment, which meant that services or trusts had to follow up on these young people before they could ask them to be interviewed. It's important to notice that they all live at home and were all in higher education, further education, or employed. Group 3, again, both male and female participants with a range of unemployment and educational status and a high proportion of comorbidity and previous or current access contact with the criminal justice system. Young people pre-transition, when we talked to these young people, it became very clear that for them ADHD equals medication, and in particular that it meant that they could fit in at school or that they had to take their medication to fit in at school. However, when we talked about transition with them, these were kind of the faces that we saw in front of us. They had very little understanding of ADHD being a potentially chronic condition, had no idea of, or perhaps had been talked about adult services, but couldn't remember anything or couldn't retain any of the information. It was all one big question mark. So someone said, I've never met an adult with ADHD. I don't know what the future holds, or I have not thought about ADHD when growing up, or I'm not worried, I'm not sure what will change. However, when we did push or explore transition or continuing services or medication, they slightly apologetically asked us to talk with their mother. And that was a rather universal answer amongst that group. So something that actually was confirmed by interviews with parents as well. Mothers in particular, but the primary caregiver is very involved in engaging the young people in both treatment and access to services. Mothers or the primary caregiver sort out appointments with services, pick up prescriptions, pick up the medication, but also follow up on taking medication, etc., etc. They also kind of monitor symptoms with the young person, and they have a better insight in when they are or are not on medication. It's also interesting to note that most young people, particularly in this group, had short-term goals with regards to their medication, whether it's mothers or relatives or primary caregivers, kind of had an understanding that their son or daughter might require long-term support for their issues with ADHD. The group post-transition showed a range of experiences and mixed emotions. For all, it was a big jump. It was something that either was scary or that they were worried about. Some were very cool about it. Others were disappointed in the first encounter with their new doctor, and others were very scared because they weren't aware of what might happen, and that annoyed them. It's important that these mixed emotions and experiences are very much related to the level of readiness of these young people when they transition into adult services. And with readiness, we actually mean their familiarity with adult services, the preparation that they've had for transition in children's services, but also any knowledge about what it would mean to be an adult with ADHD. I refer to the overview with the socio-demographic characteristics that we showed that this group of young people were all either in higher or further education and were on medication, which was what triggered the referral to adult services and their transition. Although this kind of meant that they wanted to continue medication, they all had the idea or hope that one day they would be able to be off medication. And even though they continued medication, their understanding of ADHD being a long-term condition was still very low. I'll leave you to access these quotes later as the presentations will be online. But going to the third group, those who had re-entered services, it was apparent that either they had left services by choice or not by choice. But when we talk about by choice, it was actually a not informed decision. They felt like they weren't informed about ADHD being or potentially being a long-term condition, which might have symptoms that appear differently in adulthood. And they regret not having continued medication. So the clinician didn't ask me why I stopped. If I knew what I know today, then I would never have stopped. They argue or they ask for clinicians to be more pushy when a young person actually expresses that they would like to discontinue their medication. So someone said it's just that I didn't feel that they were pressuring me enough to stay with them. After I said I don't want to be with them, they were like, all right, fine, we can't really force you. Those who left services not by choice kind of either drifted off, did not engage with treatment and did not show up, and through a number of TNAs were discharged, kind of were lost to the system. For others, life happened and life events meant that they disengaged with services. Either their doctor retired or moved area. So a wide range of reasons why they dropped out. However, what's clear for both groups is that they did not know how to re-enter, and this information was lacking before actually dropping out. I'd like to run you through 3 different scenarios of why transition might not happen, or why some young people might choose, whether that's an informed choice or not, to stop medication and therefore lose access to services. As mentioned before, ADHD equals medication for all of these young people, and medication means access to services. However, we've also seen that all of these young people experience changes in time of their symptoms, which meant that for some they thought they had outgrown their ADHD due to maturing or ADHD diminishing, which meant that ADHD was cured and they stopped taking their medication and left services. However, these young people were not informed that it might be potentially a chronic condition and that it could manifest differently in adulthood, and how to get back into services. Second scenario is where we see that ADHD is very much seen as a school-related issue, and therefore symptoms changing over time might either be the medication working and symptoms reducing. However, if ADHD is seen as a school-related problem, that means that once they finish school or college, ADHD is no longer a problem and medication is been stopped. Similar concerns here. ADHD might be chronic and might affect different life domains than just school, and how to get back into services. The third scenario really appeared or actually showed itself in group 3, who had identified themselves having ADHD and knowing that this might be potentially for life. Even though some of those young people still chose not to be on medication for different reasons. They kind of questioned whether medication was the right answer for their problem. Reasons for that might be that they learned to cope and manage it, that they wanted alternatives to medication, or that side effects were outweighing the potential benefits of their treatment. This is an overview of factors impacting good transition. I'd like to pass on back to Tamsin, who will tell you why there is this GP at the bottom of this figure.
Okay, so as Astrid says, I'm going to expand on our work with a particular group of clinicians. So although we interviewed adult clinicians and child clinicians, we also picked up on the fact that GPs were a missing group that we needed to speak to, and that there had been no specific studies in this area looking at their perspectives on transition. So where does the GP seem to fit in this whole process, and why are they important? Firstly, NICE guidance recommends that GPs should be informed and involved during the process of transition. Also, if referral to adult services doesn't take place or that transition is unsuccessful, GPs may also then become involved. And then thirdly, even if young people are managed in adult services, in specialist services, the NICE guidance also suggests that we should consider monitoring and prescribing of ADHD medication done under shared care protocols with primary care. So they also have a role to play there. So we found GPs quite a challenging group to recruit. We recruited them through a variety of avenues, and we eventually managed to achieve 14 interviews. So what came out during these interviews? Going back to this initial diagram of where does the GP fit in, the first thing that we came across was this concept of the GP becoming involved by default. So the GP became involved in the process of transition by default rather than as part of a planned process. So this might be that the young person turned up at the GP surgery saying, I've been discharged from CAMS or I've been discharged from paediatrics, but I want to continue my medication. Or it might be that they were referred to an adult service and the service fell through. But either way, the GP might become involved in that way by default. And where the GP was involved by default, the young person might turn up and say, I want to continue my medication. The GP is placed in a position where they then had to make decisions about prescribing. And this could be influenced by considerations of risk and responsibility, particularly around how ADHD medication might be seen as being something that's quite risky, often involving prescribing a controlled drug, and also involving a patient group that they might feel they don't know well because the young person's always been seen in paediatrics or CAMS up until that point. So they're having to make a decision about whether or not to prescribe. They're also thinking about whether they can refer the young person on to an adult service. If there even is an adult service, how do they find and how do they refer that young person on, and what exactly is on offer? Are they able to get any quick advice from a psychiatrist, for example, about whether they should prescribe and what dose they should prescribe? So this links into working with secondary care, which was one of our other themes. This was around the availability and offer from secondary care, but also around the relationships that GPs might have with psychiatrists. So even if the young person is accepted into an adult service, there were questions around how well does shared care work or not work? Whose responsibility is this? Whose responsibility is that? And where there was poor communication between specialist services and between GPs, that could also lead to GPs being involved by default. So I've got a few example quotes here just to illustrate those themes that I talked about. So the first one, involvement by default. This is a GP saying there's sometimes an unspoken assumption from community paediatrics that we will just take over, and the young person and their parents are told, just go to your GP and get it. By it, they mean the medication. So communication has sometimes been very poor. The second theme, prescribing. So one of the GPs here is saying, this is a controlled medication. You're giving it on an ad hoc basis to somebody that you weren't involved in the decision to give it to initially anyway. And another GP talking about the legal responsibility that they have in terms of signing prescriptions for ADHD medication, and clearly they have some concerns around that. And then working with secondary care, there's a GP here in the first quote who's talking about shared care agreements, and they're saying, it seems the psychiatrist says, I've done my bit by putting a dense paragraph at the end full of all this stuff that the GP is meant to do. And by this, they were referring to things like monitoring, keeping track of blood pressure, etc., monitoring dosage. And there's another GP here, this kind of links back to our mapping study, who's saying, I had a heck of a problem identifying a local service, and even nobody in the clinical commissioning group could identify who it was that was commissioned to provide a service for adults with ADHD. So the implications really are, what are the key messages from this? As always, resource is an issue in terms of access to specialist services and specialist advice, but we found that GPs also just wanted better communication, information and consultation with specialists. So some of the messages that they were talking about were wanting clearer documentation of the diagnosis and that the diagnosis was still applicable to that patient as they moved into adulthood, wanting to know what the ongoing plan was for transition. And they wanted that plan to be communicated with them. They also wanted information about what was on offer from services, and they also wanted some clarity on prescribing. What are the local prescribing arrangements and guidance? What are the risks and what are the side effects of continuing ADHD medication into adulthood? This was something that some of them were really quite unclear about. And this led into the GPs wanting to be consulted and to be involved on shared care arrangements locally, wanting to make sure that they were both feasible and they were acceptable to the GP in terms of what they were taking on. So just a few messages there in terms of working with primary care.
And we just want to finish again with the voice of someone with lived experience of this, of ADHD as an adulthood.
Well, as an adult, I have to be more independent when I've come out of school. So living on my own and working on my own with less of a support from family. As soon as I understand what ADHD is, I can relate it to other people. I think letting people like your boss and people you share a house with, flatmates, etc., understand what ADHD is, so tell them that you've got it and then explain what it actually means for you, instead of just like a dictionary definition, letting them know ADHD actually means that I am good at these things, I am not so good at these things. Lets people understand, and if they actually understand what's going on for you, they can be more considerate and fair to you, so your bosses can understand that you work better in certain environments and you don't work as well in other environments.
So I think that young person made it very clear that if he understands how his ADHD affects him, then he can explain it to other people and they can help him deal with the tasks of everyday life. The handout has some references. Our report is in revision with NIHR, but is very detailed and will be out shortly. We've also put up some resources where you can find more information if you wish to. We'd like to thank NIHR for funding this piece of work, which has been both fascinating, frustrating, and huge fun to do. And we'd like to thank you for your attention. And now it's over to you to answer your questions.
So first of all, thank you very much to our three speakers for a really detailed and clear presentation. We now have about 20 minutes left of the webinar for questions from you in the audience. As a reminder, if you've not used the software before, to submit a question, you'll see a question tab on your screen and you just type into that, and we'll then be able to see your questions as they come through, and I'll invite the speakers to read out the question and then take the questions in terms of responding to them. While we're giving you a couple of minutes to type in your questions, just as a reminder, the webinar has been recorded and will be available online in about a week's time on the College RSPCH website. For those of you that just want a copy or an additional copy of the handouts of the slides that have been used today, you'll be able to download those anytime between now and when the webinar closes at 1 o'clock. There is a handouts tab on your screen and you can download the slide set as a PDF file. Okay, so I think we've got our first question in, so I'll hand back to the speakers to take.
Okay, well, the first question follows on very nicely from our young adult service user, in that it says, how do the symptoms of ADHD manifest often in adulthood? That's a very good question. They do change developmentally with age. So by the time you get to the mid-teenage years, the frenetic levels of physical activity that you see with very young children have mostly faded away. So these youngsters won't have so much trouble sitting down in class, for example, or sitting down to eat a meal, but they still really struggle to maintain their concentration or focus on anything. If you talk to some people, they say it's like their brain is really crowded. You know, when you get sort of overstimulated and your thoughts are racing, that's their everyday lived experience. And because of that, it's difficult to abstract information and organize themselves in a way that other people would be at their age. And that has implications for transition. They will need more help with things like getting information, attending appointments at the right time and in the right place, particularly if it's unfamiliar, than others their age. That said, obviously, it varies for different people, and it's worthwhile talking through with your patients how it affects with them, and there will always be an interaction with comorbidities and with the environment that they're in. Thank you. So
I would like to add a few with regards to this question. I think it's a really interesting question, and actually a lot of our young adults, so the group 3 ones, talked about this and mentioned reasons why they re-entered, and a lot of these symptoms are reasons why they re-entered, and they illustrated this by relationship issues. So they had often issues with maintaining relationships, either intimate relationships as well as with friends. Organizing their everyday life was really difficult, planning things and keeping and sticking to plans. I remember an interview with a young adult who mentioned that they thought everything went really well and were well prepared to go and do their shopping. And then when they entered the supermarket or actually exited the supermarket, their trolley was full of stuff that they actually never needed. And they got home and they didn't have the toothpaste they actually went to the supermarket for. It was just, I thought, really illustrative information being an adult with ADHD.
So We have another question here, which is, you mentioned that quite a high proportion of young people had other comorbidities. Did the presence of any comorbidities affect their transition experience? So speaking first about our surveillance study of transition and about how likely young people were to experience what we defined as a successful transition, which was having attended a first appointment in an adult service. When we did some analysis of this data, we found that actually those who had a comorbidity, and specifically those who had ASD, so who had autism, appear to be more likely to experience a successful transition than those without. But we think this might be due to different service criteria in terms of who the service might accept in terms of their eligibility criteria, and it might also be to do with their level of engagement with the service or their level of parental support and how engaged the parents are. I think we probably can say more about that from our qualitative data as well. Astrid, do you have anything to add on that in terms of whether they described from the qualitative experiences of comorbidities and transition?
I'm afraid that I'll have to reiterate what you've mentioned, that it's very very different for each of these young people, as well as from information that we received from the clinicians, namely that sometimes young people experience, or that clinicians experience, that young people with comorbidities will get accepted into adult services easier. However, when we say comorbidities, we're talking about what, and I'm carefully choosing my words here, what adult psychiatrists would consider to be a real comorbidity or a real psychiatric disorder, meaning either depression or psychosis or anything else, but not necessarily ADHD is not necessarily seen as a psychiatric condition, therefore sometimes not accepted into adult services. Hence, a proper psychiatric condition as a second comorbidity might actually be a reason for these young people to be accepted in adult services. On the other hand, we saw that those who are borderline having learning difficulties were actually more difficult to transfer, because they could have gone to learning disability services. However, if you are on the threshold or just above the threshold of 70 points on the IQ score, then it was very difficult to get those accepted again. However, when they then were referred to normal adult mental health services, they weren't accepted in those services. So again, there's a mixed message, and I think the most important thing is that remit in adult service is very different between all the services, and a huge threshold for having those young people accepted. As we know from the surveillance, that's the first big hurdle, having your referral accepted.
I'm going to take two questions together now because they relate to each other. So first, are there examples of transition clinics being run by community paediatrics and adult psychiatry? And a related question about, is there really capacity for the kind of levels of need that the surveillance study identified? And what about more training for primary care, or a new workforce with primary care nurses? These are both really interesting questions. The short answer to the first one about joint clinics is certainly there are models of that happening between, I'm aware of, CAMS and adult psychiatry, and I have no reason to believe that a similar model with community paediatrics would be possible, and I think it probably would be preferable. It's a way of passing information, of focusing down the assessment, and of the young person and their family making contact with the adult service before actually having to go somewhere unfamiliar. I don't personally know of any examples, but I think it's a good model. Sorry, I see PCN is primary care networks. I think in terms of the capacity, I think there is a huge resource issue, both in adult services and also in child services. So unless we are smart and we really think about it, I think it's unlikely that adult services are just going to be able to soak up those referrals. And I think there is a need to support general practice to get involved. But I think this is everybody's responsibility. The reason for making a comment about nurses is that over the past, well, over my career, which is kind of 20 years in psychiatry now, I've seen a radical rethink and redesign in relation to how ADHD is managed, from a disorder that people were a bit skeptical about to one in which there are now clinics with nurse prescribers doing the bulk of the work. And I think adult mental health services need to have a similar transition, and there does need to be more training and support for primary care, and we need to work together. Young people with ADHD are much better served if they can get their medication when things are stable, and they're more likely to be stable if they have ongoing care close to home. And I think they'd prefer to go close to home, which usually will mean primary care. But there's no reason why primary care nurses couldn't be involved as they are in secondary care, with a bit of training and with the backup of specialist care when it's needed. But I think there is a need to test and evaluate these models to see which works best in practice. And I don't think there is necessarily a perfect model. I think it will depend on the local constellation of services, and also things like the geography. It'll be very different in, say, the Highlands of Scotland than it will be in a big metropolitan city like England or Birmingham or Manchester.
And just to add on the point of GPs involved and a bigger role for primary care, I think, as Tamsin has said, there's a need to evaluate different models, but also to bring GPs along with us in the sense of consulting them and involving them in how these arrangements are set up. So from our qualitative work, we saw that while some GPs said, this isn't rocket science, we can manage this with some access to specialist advice, there were others who felt that this was something that was very much within a specialist remit, and that being trained in ADHD alongside all the other conditions that they had to develop some sort of specialism might be a step too far. So there's also something about, as you've actually said in that comment, about how something like primary care networks could be used so that GPs who maybe were more keen or more open to being involved in ADHD management could take that over. Because when you do look at an individual practice, there will be a relatively small number of patients with ADHD in this age group who will need management.
Okay, so I'm also going to take another related question. Sorry, I'm doing these out of order, but I promise I will get to the people who've been waiting patiently, which is, how are adult services to be organised? Would it be better if it was a broader neurodevelopmental service? And I think the short answer to that is we don't know, but my gut reaction would be yes, because of the common comorbidity between neurodevelopmental problems, where actually most youngsters have a mixture of problems, and we know our classification system doesn't carve nature at the joints, so let's not compartmentalize our services and make it too complicated.
Thank you for the question. You're right, Tamsin, we don't have like stats or real data on this, and we didn't investigate different service models as such, or at least the effectivity of different service models. However, what we've learned from the qualitative is that there's, again, both pros and cons for either specialist services or for broader neurodevelopmental services. Some young people or young adults really enjoyed being able to go to a specialist service knowing that the person in front of them really knew everything about ADHD and was able to explain ADHD really well and help them coping with the symptoms, and have a thorough explanation of the medication, which they missed in children's services. Others were really frustrated by the fact that when they would attend a specialist service, that they would only be helped and treated for their ADHD, and any other comorbidities would have had to be dealt with elsewhere, which complicated, again, service access and joining up all of the different medication and access to services, which, again, for young people or young adults with ADHD is really tricky and actually led to them disengaging with services once again.
Thank you, Astrid. So somebody else has asked, do we know why some children with ADHD are missed and not diagnosed until adulthood? That's a really interesting question. I'd refer you to Kapil Sale, who is Professor of Child and Adolescent Psychiatry at Nottingham, who did a lot of work on the pathways to care for children with ADHD. And there are a series of filters. So I think one of the primary ones is the recognition of the difficulties that comprise ADHD in childhood as something that's not necessarily just willful naughtiness, and this is a child who has a problem rather than a child who is a problem. So once teachers or parents find, realize this is the problem and see GPs. In fact, GPs were very prompt to refer if parents wanted to have a referral. And then, of course, the referral needs to be accepted and there needs to be a service to refer to. Now, in children's services, I think we are doing better now with accepting and assessing children with ADHD. But I have done work which is published showing that, diagnoses even in CAMS are not always perfect. So I guess it's making sure that we have adequately trained CAMS practitioners doing the assessments so that they pick up the problems which may be comorbid with other difficulties that might mask them, that GPs are aware of who to refer to and also are supported to pick up when the problems a parent might be describing, or indeed a youngster, relate to ADHD. And very young children are not very aware of their difficulties. What they will know is that people nag them or are telling them off because they can't sit still, because they can't concentrate, and because they're impulsive and all over the place. But they won't be able to perceive that they are different than other people. But by the time you get to teenage years, they begin to be able to realize that actually other people can sit down and read a magazine and they just can't. So they might come along and say, what's the matter with me? And is that, but they need to realize that it's something that you take to a doctor and that you could get help with. So we need to have a bit more information out there. And there's some wonderful charities like the ADHD Foundation that are doing a lot to try and educate teachers and parents and the public about the problems that comprise ADHD. The next question is, did you identify how many of the children or young people who dropped out were looked after children? I'm sure we've got data on their background, but we can't really comment in terms of a proportion because this was a purposive qualitative sample. It wasn't a random sample. So we were trying to make sure that we had examples of all the different kinds of people. I'm not sure, but I will go and check afterwards whether or not we gathered looked after children's status in the surveillance data. My co-investigators are telling me that we didn't. I don't think we did. There is a limit to how many questions you can ask on a form that a busy consultant has to send back to you, and it's always a trade-off, but it's a really interesting idea because actually there's a whole other filter around children who are looked after, in that they, of course, may lack, some foster carers are brilliant and some social workers are brilliant, but they may lack the parent advocate, and therefore they might be particularly vulnerable to dropping out. And
so we've got another question here about primary care. So primary care seems a difficult group to get involved. What do you think the reason is for this? Is it lack of experience or other difficulties in management of these young people alone? And I'm just going to try and get through this quite quickly because we're pushed for time. But in terms of from our qualitative study with GPs, there are several additional points to make here. One is around local prescribing guidance. So there's a patchwork of different local area prescribing agreements all over the country, some of them saying that GPs can't prescribe at all. In some areas you can prescribe but only with specialist support. And in addition, we have the NICE guidance, which suggests that prescribing should really be done in shared care arrangements with specialist services, which is obviously very dependent on the availability of a specialist service. And there's also something about the perceptions of ADHD medication as being a particularly risky drug. Obviously, the amphetamines are controlled drugs. Atomoxetine isn't, but there are concerns about the risks of that and concerns about diversion, which is something that came up from GPs in our study. And I think they just have quite a lot of perceptions about risk, and some of which are maybe misperceptions, which could be addressed with training. But there are also concerns about the long-term effects of medication from GPs, concerns about side effects, and also I think sometimes they feel that even psychiatrists are not giving clear messages about whether adult ADHD is a real thing. This is something that they have said to us. So I think they do need psychiatrists and mental health professionals to take a lead in giving really clear messages to them about ADHD and how it should be treated, the safety of treating it, the benefits of treating it. I think all of those things would be really valuable to involve primary care. And I'll also just add workload onto that, which is always a perennial issue that GPs are facing, which is something that has to be addressed when we're thinking about sustainable models.
We've got one final question, and it's a very good and very important one, which is, do we have to use adult validated assessment scales when we are assessing a young adult? For example, an 18-year-old who was diagnosed when he was 7 years old. I think that's a really, really important and really interesting question. I think there is a need for a comprehensive reassessment at the point of transition. It's a really logical time to do it, or a bit earlier if the young person is talking about not carrying on with their medication and a controlled withdrawal of medication, because when you talk to young people who've come off and then want to come back on it, that's when everything starts to go wrong. And methylphenidate, for example, has a very short period of action, so you know very quickly if it's not going to work. And that comprehensive assessment is a mixture of good history taking and, yes, some validated scales. And there are a range of these to use, but I wouldn't say the validated scales are sufficient on their own. But I do think a comprehensive reassessment at the point of transition is really, really important.
Okay, so we've now reached the end of our questions and perfectly timed the end of our webinar. I'd like to say once again, thank you very much to our three speakers for, again, a really detailed and informative presentation. Would be really grateful if you could take some time to feedback on the webinar. There is a link on your screen at the moment that you can copy and paste into your browser to give some feedback. And if you have enjoyed this webinar, there are at least 20 further webinars that we've recorded over the last couple of years at the RSPCH. You can access them through the second link on your screen. But thanks once again to our speakers, and particularly thank you very much to you in the audience for joining us. We hope you've enjoyed it, and we look forward to you joining us again for future webinars. Thank you, and enjoy the rest of your day.